A very important topic, one that unfortunately a substantial number of our patients have to deal with, whether it be secondary to medication, co-pharmacotherapy, and so forth, but obviously life-risking issue, that is therapeutic advances in hyperkalemia, a pharmacist's guide to patient identification and treatment. And with us today is one of my favorite speakers. He's going to give you an exceptional program, Dr. Darren Grabe. He is the Associate Professor of Pharmacy Practice and Chair of the Department of Pharmacy Practice at the School of Pharmacy and Pharmaceutical Sciences at Albany College of Pharmacy and Health Sciences. He received his his doctorate in pharmacy from Albany College, where he also completed a nephrology internal medicine residency and a nephrology fellowship. He also serves as the chair of the Nephrology Practice Research Network of the American College of Clinical Pharmacy, as well as co-chair of the Medical Advisory Board for NENY, which is the Northeast New York chapter of the National Kidney Foundation, and finally founding member of the Albany Nephrology Pharmacy Program. Probably well aware of Dr. Grabe's accomplishments, but it's always an honor to have him here with us today. Dr. Grabe.
So as Randy put it, I'm from Albany, New York, and I've been there for most of my career. I took a short time after I finished my training to go to Texas Tech University and taught there for a few years and found my way back in the Northeast, and so I've been there ever since. And so today we're going to talk about hyperkalemia, which is perhaps not a topic that you have thought about as an individual topic in and of itself. And the management of hyperkalemia really follows under two sorts of scenarios. One is acute management, and for those in hospital settings, you're perhaps used to that management strategy, and that includes things like insulin, maybe bicarb, maybe albuterol, nebulized albuterol, a few things like that. And that is not primarily what I'm going to talk about. I'm going to talk about chronic management of hyperkalemia, which is something that in my clinic we deal with quite a bit. And so my clinic is a chronic kidney disease clinic. We see patients that are early stage kidney disease all the way down to the final stage of kidney disease and ultimately end up perhaps on dialysis or hopefully not. So probably in half a century, it's been since we've had options for managing chronic hyperkalemia. And often some of the choices that people make, I think, impair the opportunity to really optimize therapy for patients. So we're going to kind of talk about that. And what I'm going to tell you is the bottom line. I think that Kayexalate, sodium polystyrene sulfonate, has had its day. It's reigned supreme in this area for that 50 plus years now. But I think we have better options, and I think we actually have two now. The question is, how do they fit within the framework of managing hyperkalemia? So I'm going to try to convince you that this is the wave of the future, and you're going to see more of this. So I love this review article in American Journal of Medicine, which sort of talks about hyperkalemia from a 30,000-foot view. And what you have here is the general situation of hyperkalemia, and in the middle, you have essentially three different reasons for hyperkalemia. So redistribution of potassium from intracellular compartments, a decreased secretion of the potassium by the kidney, or an increased intake, or a combination of those things. And so part of the job in patients that come to our clinic is to determine what factors are contributing to that. And as you can see, major disease states are contributing to this, whether it be diabetes, cardiovascular disease, acute kidney injury, cerebrovascular disease, all those types of things contribute to this. And the patients that we see have several of these. Now, surrounding those four different bubbles are other conditions that fit within there, as well as medications. So for me and for you, I would think that this becomes a relatively important component of what we're trying to evaluate, and that is, are medications at all related to causing hyperkalemia, and what can we do to help manage those conditions? And so as these new binders came out, we were managing hyperkalemia in a variety of different ways, but I couldn't point to any particular epidemiologic data to sort of center on with respect to how often this might occur. and what it might mean. And so this study, which was published a couple of years ago, essentially indicates that there's about 80,000, in 2014, 80,000 emergency department visits for hyperkalemia, half of which were admitted, and a cost, of course, associated with that length of stay. The incidence of this really depends, particularly with CKD, how severe the CKD is and what definition you use for hyperkalemia. Some will use a definition of greater than 5.5, maybe greater than 6. Some people put framework that it's a mild hyperkalemia, moderate or severe hyperkalemia. Again, that's a little bit beyond the scope of this talk. But I can tell you this is sort of a not surprising, and that is on this table here, you'll notice that as estimated GFR falls, the amount of time spent at a given potassium level increases. And that's sort of a self-fulfilling prophecy. And so this actually goes back to sort of the beginning of the presentation. And when we looked at the outpatient encounters for essentially ambulatory care sensitive conditions, as defined in this study, that these are things that essentially could have been dealt with in the outpatient side of a patient's care. However, unfortunately, they were admitted and they were managed. And you can see that one of those is hyperkalemia. And some of those things perhaps might be related to that. And we know that patients were included if they CKD, and they were ranging from a GFR of 15 all the way up to 60. And that 1 in 4 hospitalizations of patients with kidney disease was related to one of these conditions. And the majority of those were either heart failure or hyperkalemia. So I guess what those slides are telling you, or should at least indicate, that this is a relatively common thing. And it may not be the primary condition that they're admitted on, and it might be. So you have to sort of look for it. And you also have to understand that a lot of that hyperkalemia is also being managed or even being ignored on the outpatient side. And I think that has some significant consequences. So here it is, this U-shaped curve here, and this is association of potassium with mortality. And you can see as the potassium drops or increases, there's a significant increased risk of mortality. And I want to point you out to one particular figure on this that I think is important, and that is this potassium level between 5 and 5.4. And that looks just above that line of identity, but it's statistically significant, which basically means that even with a small increase in potassium that most people would just say, oh, it's mild, has a risk of mortality. And so I think that's important to keep in the back of your mind. These are the major adverse cardiac events, and you can see here that as potassium goes up, the risk of these cardiovascular events increases. And you should know that, right? You know that potassium's what's in a lethal injection, so it has significant consequences. You know, many of you know that years ago they changed the top color to black tops to make sure that the risk of medication errors was reduced in the hospital setting, so the admixtures weren't pulled potassium instead of calcium or sodium, what have you. So again, a significant thing to pay attention to. Now, when you think about managing all the conditions I mentioned in the over the 30,000-foot slide, all those medications and even interventions that are non-pharmacologic impact serum potassium. So if you think about hypertension, every student that walks out of a pharmacy school these days is going to say the drug of choice is an ACE inhibitor or an ARB, both of which will increase serum potassium. Same thing for heart failure, same thing with diabetic nephropathy, heart failure, add in aldosterone antagonists. How do you manage hypertension? If we take one of those conditions out, what do? You might maximize one drug and then add another, right? You might start another drug at a maximal dose. You might start both agents at the same time, increase them. Or you might say, well, you know what? Let's have the DASH diet implemented. And as many of you know, in my population, the DASH diet becomes a problem because it's all fruits and vegetables, which have tons of potassium in them. And so we don't recommend the DASH diet. Clearly, the sodium restriction is important. but the other components are not. And so we need to be very careful about some of the recommendations that we make because they all impact that level. Now, some of you might remember this study, and this is the RALES trial, and I love this study because it was patients with severe heart failure, and they basically looked at whether or not spironolactone had an impact, and it did. In fact, they stopped it early because it had a 31% reduction in mortality, which is a huge finding in severe heart failure at the time. It was just amazing. So guess what happened? After the publish of RALES, the use of spironolactone skyrocketed, right? Everyone's going to be on spironolactone. You know what happened after that? The risk of hyperkalemia. So here we have a treatment that years ago we knew was a benefit, but many patients can't get it because they get hyperkalemic. And we know certain drugs have higher risk, and I sort of said this. ACE inhibitors, these two graphs indicate essentially two different thresholds of potassium, greater than 5, greater than 5.5. So ACE inhibitors, ARBs, potassium-sparing diuretics, and obviously as a comparator group, diuretics and beta blockers. So you can see that each class has a specific risk. You might be pointing out one thing you might just, if you dwell on this a moment or two, and I've looked at this graph maybe 100 times, but you'll notice that ACE inhibitors and ARBs are a little bit different, right? Why would that be? Don't they work kind of similar? And I thought about this for a while, and I said, I think the reason for this is that a lot of ACE inhibitors are eliminated by the kidney. And most of the patients that we put on these medications have reduced kidney function. So there may be some sort of accumulation effect with ACE inhibitors. And so one of the strategies you can think about, perhaps, is maybe switching them to an ARB. But if they're already hyperkalemic, it's probably not going to be all that significant. But regardless, that's the data. Again, same sort of story here. The lower the GFR, the higher risk of hyperkalemia. And this is essentially what this data is people monitoring potassium. So if they have hyperkalemia, they're going to get monitored more frequently. Not that it's going away, it's still there, we still need to manage it. But again, the lower the GFR, the higher the risk of hyperkalemia. And remember this fact is about kidney disease, is that starting at the age of 40 in the fourth decade of life, everybody loses about 1 ml per minute per year of GFR without any disease. That's just nature. So you add in diabetes, hypertension, smoking, nephrotoxins like NSAIDs and other things, the rate of decline is increased substantially. Now, you may not see any other adverse effects, but the GFR is reduced. And depending on the age of the patient, therefore their increased risk of hyperkalemia is just simply an age-related phenomenon. So let's look at the patient that would come to my clinic. It's a 53-year-old man. His GFR is 34. He's got diabetes, hypertension, dyslipidemia, and proteinuria. I can repeat this story time and time again. I can change the age, the gender, maybe a couple of medications, but this is essentially a great majority of my patients. And the medications are not atypical. Lisinopril, hydrochlorothiazide, atorvastatin, aspirin, metformin, and linagliptin. The lab comes back, potassium's 5.5. So I want to know what you guys would do. Would you reduce the dose of lisinopril in the patient? Would you stop the lisinopril? Would you increase the dose of hydrochlorothiazide? Would you add furosemide, or would you add sodium polystyrene sulfonate or Kexley? Okay, so guess what? All over the board, right? Everyone has a different opinion. And you're just like everybody else that's been studied this question. The different audiences I've been in, as well as some study data. So if you look at this is a published study in 2016 where they measured what the response would be by physicians if this in fact would happen. And they had a little bit more data here, and I kind of cheated because I didn't give you all the options. I was only limited to 5 choices, but greater than 5 and greater than 5.5, what would you do? And you can see if you run through the numbers here, everyone is going to do something different. All right? Would they send it to the emergency department? Would they repeat the serum potassium measurement? And clearly that is something we would do. Prescription for SPS, diuretic changes, ACE-ARB changes, all over the board. I don't think any of those choices, other than perhaps repeating the potassium to see if it's true, is necessarily a reasonable option. It may actually cause more harm. And you minimize optimal therapy for the patients. All right, so let's go back to some physiology. Which part of the nephron is responsible for potassium secretion? Is it the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, or the cortical collecting duct? Guess what the right answer is? It's D. Okay, well, let's talk about some physiology. So what's normal? So I always teach my students, or anyone else I talk to, it's hard to know what abnormal is if you don't know what normal is, right? We always focus on the abnormal, but you have to know what makes sense. And so this is a picture which generally says GI intake, what goes in, what goes out, right? If you eat 100 milliequivalents of potassium, you're going to get rid of 100 milliequivalents of potassium. The majority of that, greater than 90% of it, is going to be peed out, right? So if your kidneys don't work, potassium goes up, all right? It's an intracellular cation, so the serum potassium is a very poor marker of what the total body stores are, all right? A typical 70-kilogram guy, I haven't met him yet, but he has about 4,000 milliequivalents of potassium in the body, all right? And the very small percentage of that, 56 out of 4,000, is extracellular. That is what you're measuring in the serum and trying to guess what's in the rest of the body. So again, that's very important to understand when potassium is being shifted from one place to another. We have an average U.S. diet and a recommended daily allowance there. The cortical collecting duct is where all the secretion primarily occurs, and that is under the influence of a number of different factors. And so here's my handmade drawing, which looks probably more like an ear than perhaps a kidney. It's a little hydronephrosis here in the upper pole. And we know that we have lots of therapeutic interventions, and I stuck in renin inhibitors, although we never use them. Decreased arterial blood flow releases renin, which triggers the cascade to eventually release aldosterone, which increases our blood pressure and reduces potassium. So what happens in a cortical collecting duct is certain triggers will impact potassium secretion, and most of that has to do with sodium delivery to that site. And so the more sodium that gets delivered to that site, the more likely you are going to shift potassium secretion. And so here in our cortical collecting duct, we have sodium delivered, which will be transported by the epithelial sodium channels, which in exchange for potassium will be essentially excreted. There's one competitor for this, that is chloride. So if we have a lot of chloride reabsorbed, you'll see a blunting of the effect of this sodium channel distribution, meaning that you'll have essentially less potassium secretion. And sometimes you'll see that with a drug like amphotericin, for example. Amphotericin has that effect where you'll see hyperkalemia because of the change in chloride redistribution. So there's a couple things that happen, and so we have a very a great ability to increase and decrease potassium secretion in the kidney. It's an exquisite organ, and so I can't get away from talking about some physiology in a talk like this. And so we can upregulate or downregulate the number of active sodium channels that are in this cortical collecting duct. And so much so that we can decrease our potassium excretion to about 10 milliequivalents per day, and we can ramp it up to about 400 milliequivalents per day. And that's in a healthy kidney, right? And this is essentially done by the secretion of aldosterone. That is the stimulus for the generation and activation of these sodium channels. So the nephrologist I used to work with used to say, hyperkalemia waits for no one. And which is kind of funny, but what he meant by that is exactly the statement I said before, is that most of the potassium lives inside cells. And we don't really have a good idea of how quickly those potassium levels shift. And so even though the potassium is 4.5 today, they might be just on the threshold of tipping the balance, and that extra potato in the morning, the home fries, could put them over the edge. So even though we measure potassium 4.5 today, tomorrow it's 6. So it doesn't take much. And it doesn't take much with other influence with regarding medications or underlying disease. So there's a number of adverse effects that are related to hyperkalemia that often go unnoticed because there's other things going on in the patient. So how do we manage it? Well, so this is all the different options to manage hyperkalemia. And you'll see the SPS here. You have Patiromer, you have temporizing agents, mitigation of other risks, all over the board here. And so these are all the studies that have been done for those various types of interventions. So the green represents observational studies. The blue represents non-randomized controlled trials. So a smaller piece of the pie are actual controlled trials. And so if you filter down even more, what you'll find is that we have very few studies talking about management of using drugs for hyperkalemia. So again, very small amount of data to make important decisions, essentially, is that. Okay, so another question. Which of the following serious adverse events related to SPS, Caxlate, resulting in an FDA safety labeling change? Was it exacerbation of heart failure, elevation of blood pressure, development of colonic necrosis, or risk of acute kidney injury? So the answer C, development of colonic necrosis, is the right answer. And I'm going to come back to that. So we have essentially current therapy. So the temporizing agents are really things like insulin and dextrose, albuterol, hemodialysis, what have you. We also have sodium polyacetylene sulfonate, Caxlate, Patiromer, and a new one, sodium zirconium cyclosalicylate. All right, so we have some new agents on the block. So let's talk about the old one. And there's a bunch of information here, but in essence, the dosing is all over the board. You may see that. In fact, the best order I think I ever saw was Caxlate Stat in the hospital, which always makes me laugh because it's not working until a day from now, at least. So it's been around forever. Most of the studies that got on the market were essentially a small group of patients. The cost is still significant. I'd be curious because I think most of you are in institutional pharmacy. So I'm kind of curious, guys, how you're ordering that because I think it's hard to get by. And my understanding, at least the hospital that I work with, is that they're ordering the 1 pound jars and mixing it in the pharmacy. So again, I'm kind of curious to see what you guys might be doing. So there's a number of issues. There's no rigorous clinical trials to determine its efficacy or safety. It takes many hours to work. It doesn't really work all that well in emergent hyperkalemia. We actually question whether or not it works at all without the combination of sorbitol. When that drug was released, it was released in powder form in the 50s and mixed with water, and they realized quickly that it caused a ton of constipation, so they abandoned that and mixed it with sorbitol. And now we're back, I think, a little bit more mixing with water. There's safety concerns, which I sort of talked about with the question. There's drug interactions and some issues there, and obviously mixing and dosing and palatability. It's like drinking sand. Okay, the approval was a study of 32 patients. There's been some retrospective analyses which essentially supports some of its efficacy. It's most often combined with sorbitol. And I went searching for an actual clinical trial that had some rigor behind it, and I was lucky enough to find one on the registry. However, that study, under study conditions in a controlled environment, was prematurely terminated because of the high rate of adverse effects in the Kexley group. So in modern times, the drug just couldn't stand up to a controlled trial environment with the best patients selected. It's a prospective randomized single-blind trial with under less than 100 patients. It did reduce potassium, but a significant rate of adverse effects. There's a 33-patient study, double-blind, placebo control. Good rate of potassium reduction, but small sample size and increased rate of adverse effects. The colonic necrosis is there. It's very rare, which is important to point out. We're looking at maybe 0.3%. So if you use it enough, or the patient uses it enough, or enough patients get it, you may see it. And these are all basically the data that support that. The FDA also put out a letter that essentially said that you should separate the dosing of Kexley by 6 hours on either end with any other medication. So if you remember the one slide that talks about the dosing, you can dose this up to 4 times a day. So no other medications technically could be given in that period of time when they're getting this drug. Now, most often we'll see it given once a day, but that 6-hour window on either side really makes it challenging. And to be honest with you, there's not a ton of data on this. And when you look, you'll see a couple of studies here, quetiapine, lithium, iron, all are significant reductions in the exposure to those drugs when combined with the drug. All right, so switching gears a little bit. Patient calls, is prescribed Patiromer, asks how long the product can be left out of a refrigerated environment, and what is your response? It is a 1 week, 1 month, 3 months, or it can't be, it needs to be refrigerated. So it does need to be refrigerated, but it actually, once it's left out, it can be left out for 3 months. So it doesn't even, so that actually creates some storage concerns really for the pharmacy, I think, to be honest with you. It comes in bigger boxes. It's a little bit harder to store depending on how big your fridge is and what else you might have in there. You know, you got Copaxone in there. You're starting to stack up boxes and trying to figure out what you get. So normally it's ordered and it's bringing by the wholesaler for the patient to pick up. So again, that's the answer there. All right, so let's talk about Patiromer. There's just some data on here that I'm happy to share. You can get this at the official label. But it comes in different dosages, 8.4, 16.2, so on and so forth, 3 different doses. The typical starting dose is 8.4 grams. Most of the patients that I've used this in don't go above 8.4. We have a couple patients that go up to 16.2. I have not seen one patient that's needed 25. So typical dose for most is 8.4 grams. It's a powder packet, so it has to be mixed with water. There's some education that needs to happen for the patient in order for this to be effectively taken. They need to put 1/3 of a cup of water in a glass, then add the powder, mix it, drink it right away, and if there's still residue, you add a little bit more water and drink until the residue is gone. It doesn't taste bad. It's pretty well tolerated from a palatability point of view from what I've heard from patients. But it is some specific guidance in terms of how you mix that. And there's a nice little video that the company puts together that is helpful to show patients. But you need to recognize that they need to be educated about that because they need to get the proper dose. So this is a potassium exchange ion. The difference here is that, 1, you'll see it's more effective. 2, it's not exchanging it for sodium like Kexley, it's calcium. And so some things to think about that calcium exchange that might be coming long-term, or that calcium exposure long-term might have some impact. When the drug was first released, it said you had to take it with food. And so here's this Tourmaline study. It basically says it doesn't really matter. With or without food, it doesn't matter. It's going to lower potassium. And you can kind of see it works in the first couple days, and it has a persistent effect over the time you're taking it. When the drug first came out, it had a box warning talking about drug interactions. Basically, you had to separate it by 6 hours on either end. That was modified after some additional studies showed that it really doesn't interact with the majority of these types of drugs. It's only a handful, but the package insert will say 3 hours. To be honest with you, I think it's just a handful of the drugs, and it's the usual suspects. Levothyroxine, the quinolones, the ones that you're used to. So they redid the study, and they looked at these ones that had a significant interaction. The study that got the box warning was an in vitro study. So they did an in vivo study, and they looked at 12 meds, and that led to the labeling change after the drug was on the market. There were essentially 3 clinical trials that got the drug to market. I put the jewels in there because it just helps me remember what an amethyst looked like, an opal, and a pearl. I don't know if I knew what an amethyst actually looked like, but now I do, and I'll never forget it. So, but they all looked at something different. So the amethyst is a diabetic nephropathy trial, so patients with diabetic nephropathy. HK was patients essentially with hyperkalemia, and the HF at the end, the pearl, was patients with heart failure. There were a dose-finding study, a safety and efficacy trial, and another safety and efficacy trial in those patient populations. And I know it's late in the day, and the last thing you want to do is go through study data, but the bottom line is it worked in all of them. And I'm just going to show you some quick data. And there's something important here, and it's the reason I want this to be shown, is that it works within a couple of days, right? And you see potassium levels drop significantly. The difference in the color lines is this mild and moderate hyperkalemia. It didn't matter. They both went down. And they stayed down, and this is a long trial. This is a year-long trial. And when they stopped, it took 3 days for the potassium to go back up, which basically means you have to stay on it. But there's a little trick at the end. I'm going to give you a pearl, not a pun intended on that one, but I'm going to give you a pearl of wisdom here. Again, the hyperkalemia patients, didn't matter who they were, potassiums went down. This is the heart failure trial. So this is patients put on spironolactone. Potassiums went down if you took the drug and went up if you didn't take the drug. So if you remember the RALES trial, right, we couldn't use spironolactone in these patients, and now you can. Additionally, this study was published and essentially showed that not only do you get the benefit of potassium, now, and I guess it's off-label, please recognize that it's not an approved indication, but it also showed a reduction in aldosterone levels, and subsequent to that, a reduction in blood pressure. So, sort of interesting findings, I think. Now, what are the issues with Patiromer? Well, it doesn't work right away. I mean, you can't give it and expect it's going to be working in an hour. So for an acute hyperkalemic episode, you're still waiting several hours for this thing to kick in. And the full effect isn't until 2-3 days after. So again, probably a hospital emergency room drug, maybe to start, but not what you're hoping to, prevent death right away. It does lower potassium, so it actually can cause hypokalemia, so you need to watch that, as well as magnesium needs to be watched. So about 3, 4, 5% of patients will get hypomagnesemic. There are some drug interactions. So metformin, levothyroxine, Cipro are the most significant there. So if they're on there, you definitely want to separate the drug out. And since a lot of these patients have diabetes, metformin is going to be one of those things we'll pay attention to. It is a higher cost, and so there is a cost associated with the drug. I'm going to talk about a recent study that maybe argues that it's worth it. And then I'd mention the mixing, administration, and storage issues. All right, so let's ask the question. Prescriber calls about what the starting dose is, and titration. What is the starting dose? Is it 8.4 grams once a day, 8.4 twice, 16.8 once, or 16.8 twice? So before I go to there, there's a couple things about the dosing. You're titrating it weekly, which means you're going to start at 8.4 grams. You can measure potassium if you want, and if it goes up, well, then you need to react. But you're not going to, you're typically going to measure potassium 1 week after starting the dose, and if it's still high, because remember, it takes a couple of days to kick in. So at the seventh day or thereabouts, you're measuring a serum potassium level, and if it's high still, then you reduce or you increase the dose to reduce it further. Like I said, most of the people we deal with get away with 8.4 grams 16.8 for some, or 16.8 for some. I've never seen anyone on 25. So the newest one is a drug I used to call ZS9. The branded name is Lokelma. And this had a little bit harder road, I'd say, of getting to market. And so this was, and I gave a little bit of history, and I omitted one step to fit in the last one here. And this was on the same track as the Patiromer drug. In fact, we thought when Patiromer was approved a couple of years ago that this would be approved at the same time. However, there were some manufacturing issues going on. Not that the drug didn't work, but something going on with the plant, and the FDA denied it. And then they went back again, they denied it again. And then so it took a couple extra years for this drug to get approved. And so it was approved in May of this year. And I think what you found is I think a lot of people were hoping for both. They can compare both. Hospitals deciding, well, which one are we going to put on formulary, or we're going to have to pay attention to this. And in the end, I think Patiromer is probably on a lot of formularies. It's certainly covered by the majority of health insurances across the nation. And so it got a foothold and had a couple-year head start until this drug is approved. The difference maker for this one is a couple of things. And one, it works quicker. And two, it's got a bigger company behind it. So AstraZeneca markets this, and they got a lot of muscle. And so you're going to probably see them market this drug in certain areas quite heavily. And I think it has some advantages, but also some disadvantages, which we'll talk about. So a couple trials, and I'll go through these relatively quick. HARMONIZE was one. It was a 48-hour open-label initial phase. And these were patients that had potassiums, obviously greater than 5.1. They looked at a couple different dosages. Again, they had a 48-hour open phase and then followed by, essentially, it was a 4-week study. Now, it's interesting to remember that because if you look at the package insert, it says the initial dose should be essentially about 10 grams 3 times a day for up to 48 hours. And then you pick a maintenance dose beyond there. And so it kind of follows the HARMONIZE trial dosing. The drug work, and so the previous slides that talked about Patiromer were in days. These were in hours, okay? Now, this is off-label, but I'm going to tell you that it's not used for emergent hyperkalemia, but you may see that, in clinical practice outside of labeling, and we see that obviously all the time. But you can see potassium levels drop literally within the first hour and significant drop right away. And then you can see a day later, potassiums are within normal range here. And you can see the dosing on top of how often they gave it. So you may, if you're in hospitals, you may see this drug get in there, right? Knowing it's off-label, but it may sneak in there and be another therapy that's started. And I think it's probably better at it than Patiromer, and certainly better than Kexley. It didn't matter who you were. So this is just a bunch of different patient populations on the bottom here. Chronic kidney disease, eGFR ranges, heart failure, diabetes, the level of potassium didn't matter. Before and after, top and bottom, potassium went down. So drug works. Adverse effects. All right, so here the thing to point out is very few adverse effects, except for one that sticks out like a sore thumb, and that's the edema. And so the higher the dose, the more prevalent edema. This is one that exchanges it for sodium, which has me a little bit concerned, only because that's what Kexley does, and when you exchange sodium for potassium in certain populations, maybe you cause some other issues. So keep that in mind. So the dosing that the package insert will say is 10 grams daily as a maintenance, up to 15. So you can see that you're going to find anywhere from 6 to 15% of the patients getting edema because of that. And you may see that already and may worsen it in some patients. This is another trial that was published in the New England Journal a couple years ago. Again, phase 3, steepest decline in the first bit of time. There's a dose-ranging study, and the majority of patients were there very quickly. And again, I'll just sort of go through. The different lines here indicate the different dosages. And again, the drug works, and it works fairly quickly. So I think when you're thinking about putting these into clinical practice, I think it requires some thought. Number one, I haven't had any clinical experience. That's my caveat to you with ZS9 or sodium zirconium cyclosalicylate. That's a mouthful. Or Lokelma. It's too new to market. We have not used it. I did get a call from a colleague of mine in central New York asking about the two and formulary inclusion. So again, I don't know how that's going to fit. I do think it's probably a better drug for the hospital for acute management or that interacute time frame, perhaps. But I have a little bit more experience with Patiromer. Our struggles with Patiromer is a couple of things. Number one, it requires some effort to get covered. The company does the usual thing where they can give a patient a month supply and then work on the coverage after. So that's important, I think, because it at least gets them that initial therapy, which is important. And maybe that's all they need, to be honest with you, until we figure out diet or other interventions. This is essentially the treatment category. This is the different studies representing it. And so you can see that ZS9, Patiromer have a ton of data that they've been publishing on this stuff. And you can see how that compares to all of our other interventions. So if nothing else, I walk away thinking, okay, they're paying attention and they're getting the data out there for us to rely on and make good decisions. So I think that's important. What else? Patiromer, I talked about the storage issues. There's no storage refrigeration needed for Lokelma or sodium zirconium cyclosalicylate. So that's a benefit, I think, as far as storage is concerned. It does have a mixing thing. I think the ZS9, you have to mix with 3 tablespoons of water and then drink and then mix again. So it's kind of a similar procedure, but not so rigid, it seems, that Patiromer has. I think counseling is certainly important, and that is our bailiwick to make sure patients are properly counseled. I think, for me, when I think about hyperkalemia, I think about the number of times over the history that I've been in where we're managing proteinuria, we're managing hypertension well, we have opportunities for heart failure patients, we have slowing progression of kidney disease with ACE inhibitors and ARBs, and oftentimes we're stopped because of hyperkalemia. And we have to kind of roll it back, and we're like, well, what else are we going to do? Well, there's some data with non-DHP CCBs and using them in diabetic nephropathy, but it's not that great. Well, let's go ahead and do that. Or let's add a loop diuretic and risk other issues. So it's not been great, and I think there's an opportunity here. And so one of my concerns is it's a costly drug. It's going to cost some money of the patient, out of pocket perhaps. That is a concern. When you look at a cost-effectiveness study that was published just a couple months ago, it seems that regardless of every iteration they made, and they used a Markov model, which essentially shows, well, it's not worth getting into, but they used a Markov model, very strong one, and to predict what would happen. And 98.8% of all of the calculations they did, every single time in the patient population they studied, adding Patiromer was a win. And it remained to be seen about this drug, of course, the ZS9. So every time is a win. Quality of life, years gained was beneficial. Reduction of hospitalization costs was beneficial. So it cost more money, but in the end, it was a cost benefit to be on that drug. And these are patients with severe heart failure that were either on ACE inhibitor alone or combined with ACE, Patiromer, and spironolactone. So again, I think, like I said, Kexlete's day is done. Lessons learned, again, I kind of talked about these. SPS, I think we need to be done with it. We have 2 new agents, and I think they're both effective. I think hyperkalemia is common, more common than you think if you're looking for it, and especially with those small deviations above that 5.0. Multiple risk factors, and we know that medications that we love and hold dear to our hearts, pun intended, can cause hyperkalemia. And I think we have an opportunity to improve the outcome of those patients, not just because of hyperkalemia, but overall. So thank you very much for your attention.